Hello from me. First, I want to thank my mentor, Dr. Antonogiannakis, Manos Brilakis, and the rest of my clinic for the kind invitation. So I will speak about the perfect Bankart repair. First of all, from evolution, our feet are made to go away from the problem, but the shoulder helps us to stand and fight for our needs. It's the most flexible, the most complex, and it has the greatest range of motion from any other joint. For all these reasons, it sacrifices stability in order to take mobility. And the labrum, this ligament, helps us to increase the diameter of the glenoid. What is stability, actually? It's a biomechanical dysfunction, failure of static and dynamic stabilizer, and ranges from mid-subluxation to a traumatic dislocation. And actually, it's a traumatic event for the athletic individuals. It's quite often 50% of all major joint dislocation and 2% of our population. And the entity, it's multifactorial. Actually, it's not a black and white issue. In most common presentation, it's a patient with some degree of laxity dislocates his shoulder from a minor or a major accident. And this is Bankart, who first discovered the essential lesions 101 years before. So what is Bankart? It's an avulsion of an inferior glenohumeral joint, and it starts from 2 to 6 o'clock. This is the primary strain in the upper position. It's quite often as a lesion, but not the only one. And this is a study from our clinic with a lot of citations that shows exactly these things. That when you have a dislocation, you can have a lot of lesions. And the most important is that the major lesion can happen from the first dislocation. And as we have recurrence, this becoming worse. As I said, Bankart and heel sacks is the most common lesion, but also important is that from single dislocation, we can have glenoid bone loss, and 8% from these patients can have arthropathy. So, how to treat these dislocating shoulders? First of all, we need a plan. We must categorize these patients, and we can use factors as activity level, number of dislocation, shoulder laxity, bone defects, and revision surgery. And this is an innovation from IC score that have also some parameters more, like on-track, off-track concept. Previous speaker spoke about more than me. And what is the principles of therapy? We have to restore the anatomy in order to restore function. And actually, our job is easy. When we have no bone loss, 1, maybe 2 dislocation, we may have a Bankart repair. Or bone loss more than 20%, we go for a bone procedure. But what happened in this gray zone, in this no man's land, that you have less than 20% bone loss, and you have some factors that may have a result in the stability of the patient. And first, we went open. It was a gold standard for years. The success rates were high, but now it's the age of arthroscopy. And the goal of the operation is restoring the labrum to its anatomical attachment, re-establish the appropriate tension of the glenohumeral ligaments and the capsule, restore the bony defects, and repair if we have the rotator cuff tears. So we have 2 positions that we can perform the operation, is the lateral decubitus and the B chair. In my opinion, if you go lateral decubitus position, in the anterior superior portal, you may have better view. But most of the times, it depends in which position you are familiar. I may be wrong. As I said, we have three portals, the posterior portal, the anterior superior portal, and anterior inferior portal. And the first step is to identify and define pathology. The next step is mobilization of the anterior labrum, so we need a saver to debride any frayed edges, labral elevator and angle rasp to mobilize the labrum, and a hook ablator we use sometimes. So nowadays, the golden standard in anchors is all suture. Why? Because we present the bone stock, we have smaller holes, we improve the postoperative images, it's easily revised if we need, and we have smaller osteolasis and cystic formations. So, in my opinion, we need minimum 3 to 4 double-loaded anchors, because in that point we have more points of fixation. Typically, we place this anchor in 530, 4, and 330 in a clockwise position, and the average distance is 5 to 7 millimeters. But why not placing an anchor in 7 o'clock to these patients that they have very lax posterior capsule, because we know that the inferior glenohumeral ligament is very important. So we put these anchors 2 millimeters from the edge of the glenoid, or some others prefer to put it in the glenoid rim. Also, another trend is to remove the cartilage from the anterior edge in order to enlarge the bony bed and optimize labral tissue healing. But in other hands, we have some reports that this may lead to stress shielding and resorption of the anterior part of the glenoid. Another thing is that we need a very delicate, very small suture passer, in my opinion, in order not to damage the labrum and the capsule. And our goal is a proximal shift and restoration of the capsular tension. We may use some extra techniques like Max Stitch or a Enrico Gervasi technique. I don't have a drawing for this, but it's passing the strand of the suture multiple times from the capsule and the labrum. And this is the final result. Okay. And this is a systematic review, long-term outcomes. 9 study, 822 shoulders. The conclusion, excellent long-term function, but high rate of recurrent instability, 16%. We may argue all the day that this percent may be higher or may be smaller, but I want to share my thoughts. Are we comparing the results for the same technique? I mean, all these patients have the same number of anchors? Is the technology of the anchors instrumentation the same 10, 15, 20 years before? Are the patients fitting for the criteria for Bankart repair? So we may compare apples and oranges. And we know the risk factors for recurrent instability from the Bankart repair. What may be the future? Innovations and anchors and stabilizing methods. New surgical decision-making algorithms. In this situation, the artificial intelligence can help us. So, in my mind, the take-home message is it's a procedure with low morbidity. The anchors equipment that you use have low complication, is easily revised, in selected patients can have good results, can be combined with other procedures, and stay simple where you can. And I was here from the start as a participant, and now as a speaker, and I will be in the future, and that's a threat.